Okay, so let's talk about one of the biggest showdowns in medicine right now. On one side, you've got metabolic surgery. And on the other, these new game-changing drugs, the GLP-1 agonists. Now, we know both are incredibly powerful for weight loss, but the real question is, how do they stack up when it comes to protecting your heart? And well, the answer isn't so simple. The reason why is that the scientific proof we have for each, it's just fundamentally different.
So let's just cut to the chase. The question really boils down to this. Is a one-time, major, life-altering surgery the better bet for your long-term heart health, or is a simple, consistent, weekly shot the way to go? To even begin to answer that, we've got to look at the evidence.
All right, let's set the stage and introduce our two contenders in this heart health showdown. In one corner, we have a well-established surgical approach that's been around for a while. And in the other, a revolutionary new class of drugs that has totally shaken things up. Both are super effective, but they work in completely different ways. And, this is the crucial part, they're backed by very different kinds of proof.
And this slide really breaks it down perfectly. Think of it this way. Metabolic surgery is a physical alteration. It's like a permanent hardware update to your body's anatomy. GLP-1s, on the other hand, they're more like a software patch. They're medications that work with your body's own hormones to manage things like appetite and blood sugar.
Okay, first up, let's make the case for metabolic surgery. Its single greatest strength, the thing that makes its evidence so compelling, is just the sheer amount of time we've been able to watch what happens to patients. We're not talking years here, we're talking decades. And this is where surgery's case really shines. I mean, look at this. We have studies that have followed patients for 10, 15, even more than 20 years post-op. That kind of long-term perspective is just invaluable. And it shows us that the benefits we see aren't just a flash in the pan, they are incredibly durable.
And the numbers? They're pretty staggering. These studies show what's called a hazard ratio of 0.4 to 0.6. So what does that even mean? Well, in plain English, it means that patients who get the surgery appear to have a 40 to 60% lower risk of having a major heart event compared to similar people who don't. I mean, that is a massive, massive effect.
But, and this is a huge but, this powerful data comes with a major asterisk. You see, almost all of it is observational. This means scientists are just watching groups of people over time. They're not randomly assigning who gets surgery. And that opens the door to all sorts of potential biases. You have to wonder, right? Are the people who choose to go through with a major surgery maybe more motivated in other ways that also protect their heart? It's really hard to say for sure, and we can't completely rule out these other factors. Okay, now let's pivot to our other contender, the GLP-1s. The case for these drugs is built on a completely different kind of evidence. The data might not stretch back for decades, but its quality? It's considered the absolute peak of medical science.
The evidence for GLP-1s comes from what are called randomized cardiovascular outcome trials. Now, this is the gold standard for a reason. In these studies, patients are randomly assigned, like a coin flip, to get either the real drug or a placebo. And that randomness is the magic ingredient. It wipes out all those biases we just talked about and lets scientists draw a direct causal line from the medicine to the result.
And the results from these trials are just undeniable. Across multiple huge studies, these drugs have been proven to reduce what's known as MACE, major adverse cardiovascular events. We're talking about a solid 12 to 26% reduction. Even in the big SELECT trial, which looked at people with obesity but not diabetes, they saw a 20% drop. This isn't just an association, it's proven cause and effect.
But, just like surgery, the GLP-1 evidence has its own limitation. And it's basically the flip side of surgery's strength. Time. You see, most of these gold standard trials follow patients for 5 years or less. So while we know for a fact they work and protect the heart in that medium-term window, the really, really long-term picture, well, it's still coming into focus.
So we really have two compelling stories here, but they're being told in two totally different languages. On one hand, you've got this long, detailed history book full of strong patterns and associations. On the other, you have a rigorously controlled lab experiment with a clear, definitive conclusion, but just a shorter timeline.
And this table just lays it all out, side by side. For surgery, you get those decades of follow-up showing a really strong association, but you have to live with that potential for bias. For the GLP-1s, you get a proven causal link from the best kind of trials, but you have a shorter track record. It's the classic trade-off, isn't it? The quality of the proof versus the quantity of time.
So naturally, people have tried to compare them head-to-head using real-world data. And what's really interesting is that these studies often suggest that surgery might be even more effective at reducing heart events. But that word suggest is doing a lot of work there, because these are observational comparisons. They run into the exact same potential bias issues we've been talking about. So the findings are, as the experts say, hypothesis generating. They give us some great ideas to test, but they are not the final answer, not by a long shot.
Okay, so where does that leave us? Well, instead of asking which one is better, maybe the more useful question is, what is the purpose of each one? Because the evidence really seems to point toward two very distinct and very powerful roles for them.
And this slide really gets to the heart of that trade-off. On one side, you have surgery, which offers durability. It is a profound, one-time intervention, and we have seen its effects last for decades. On the other side, GLP-1s offer scalability. You can't just go out and perform surgery on millions and millions of people easily, but you absolutely can prescribe a medication, allowing you to protect a massive population.
So here's the big takeaway. Both of these are fantastic tools, and we know they both reduce cardiovascular risk. They just come at the problem from different angles, and they're supported by different kinds of proof. Surgery's strength is that incredible, durable, long-term history of benefits we've observed. And the GLP-1 strength is that undeniable causal proof from the best scientific trials we can design.
And that really leaves us with the ultimate question for the future. As we keep gathering more long-term data on these drugs, and maybe even one day get randomized trials comparing them directly to surgery, will a clear winner emerge? Or, and this feels more likely, will we find that these two powerful approaches aren't rivals at all, but instead they're complementary partners in the long-term fight to protect heart health? You know, only time and a lot more data is going to tell us the answer to that.